if you look at the printout here in the book, it's ventricular support with a bi in front of it. So I interpret it as to talk about the present and the future of assist devices with special respect to biventricular support. And if you look at that old photo from '89, that was biventricular support, how I saw that when I started my residency, and I think that is no current state of the art anymore. And if we go to the total artificial heart, it's old technology from 1969 that has some improvements, but it's still the technology from the Apollo age. And so I think this is also not the state of the art. And we have discussed the situation in the UK and in Germany is almost as bad if you compare the number of waiting list patients and transplants. So in Germany we do like 350 transplants and we have 1,000 patients on the waiting list. And so I do think that these old technologies, biventricular support with pneumatic devices, should not be used anymore in countries that do not have the bridge to transplant ability within a limited time factor of, let's say, 180 days. And I think this is what these devices were made for, and I think we cannot need this anymore. You have heard about this, that if these estimates are true, that you have about 100,000 patients in this country, in the US about 300,000 patients that require some form of ventricular support. I think we are not talking about transplantation anymore. And where are we at the moment? We are with these patients who were on the devices for 6-7 years on the HeartMate 2 and do quite well. And we are really supporting patients and giving them ability to survive. And with this study, we could show that the patients in the study had an 80% 2-year survival, but they were only expected to survive 40% when they were kept on medical therapy. So this therapy can be done, and it's really creating a survival benefit for other patients. So what do we do with biventricular support? Well, Andreas Zuckerman pointed it out, avoid biventricular support. This is the most important thing, and I think many programs already adopted programs to stabilize patients before, to have their own algorithms to do that. And I want to show you, spend a couple of minutes on this short video, because I think this is important to avoid biventricular support, because it shows an implantation of an assist device off pump, so we don't use cardiopulmonary bypass anymore. You see this patient has a limited anterolateral thoracotomy, and the sewing ring is put on their heart while the heart is beating. And the idea behind it is, if you have a patient, although on catecholamines, why do we expect you have to put in a biventricular support? The patient should benefit from the implantation of an LVAD and thereby improve their circulation. So why should there be a need for biventricular support? So once this is finished, the question is how to implant a VAD without putting the patient on a ventricular assist device. We, I think, improved our technique since this video a little bit because we give our patients at 2 times during the procedure a shot of adenosine, and that stops the heart for about 10 seconds. And this is the time to do the incision and the pump placement. And we didn't have this technique when we did this movie, so we will see that this will be a little lot lost later. Another important thing is to locate the place where to put the pump. And we learned that with this needle in the apex, I think it's a great trick to define the right spot where you want to put the device in. And although with the use of 3D echocardiography, you can see the needle blinking up there in the apex, it has emerged as a very valuable tool to really find the place where you want to put the device and to ensure optimal placement of the inflow cannula. These are 2 important tools, and Now, here comes the part where the ventricle is opened, and so it's with a knife, and then the coring device is put into place, and then there's a coring of the apex, and of course you have to be absolutely sure that there is nothing in the way, and the implantation works nicely. So clean up the mess and move on with the drive line implantation, and then there's another small incision as a upper hemisternotomy, so the outflow graft is tunneled through the pericardium to the ascending aorta that way, and then the procedure is finished within a quite easy intersite anastomosis you would expect to the ascending aorta. The airing is done through the device, and then of course there is the last step, the anastomosis. And now you see that the device is sitting really where it is supposed to sit, and you can see that on the 3D echo that the center of this cross or star is really at the apex, and I think that is very important for this procedure. So we did this in 25 consecutive patients since last year in June. It is the usual patients we have now. We don't do Intermex class 1. We put Intermex class 1 patients on ECMO first, and then do the implants on Intermex status 2 and 3. 7 patients had prior surgery, so that is not a real problem. The implantation was done like you have seen in the movies. We had an OR time in between 100 minutes and 170 minutes. Although it looked a bit bloody on the picture, our mean blood transfusions rate was 1.2 blood bags per procedure, and 11 patients went without transfusions, and none of these patients left the operating room with a hematocrit below 30. So I think it's a blood-saving procedure. In the outcomes, we had no death so far. Conversion to on-pump surgery was done in one of our first cases, where the circulation was getting unstable, and I just felt not right to move without cardiopulmonary bypass. I think we wouldn't do it nowadays, but it was the beginning of our experience. We had no right heart failures. ICU stays was 1 to 4 days. One rethoracotomy we had to do with the refixation of the LVAD in a small female patient with a hypertrophic disease, where we found out that the device had to be fixed in a certain position, because when she started spontaneous breathing, there was a problem with the inflow. So I think that is important. No cardiopulmonary bypass, no opening of the pericardium, and I think this is one strategy to avoid biventricular assist devices. But what do we do if we have to do biventricular assist devices? First thing is, I don't believe in any scores. I know there are many scores around, but like these colleagues from Canada pointed out, any assessment of the right ventricle is load dependent, more or less. So when you optimize the patients prior to surgery, you can avoid all scores for right ventricular assist device implantation. And it also shows that the right ventricle is afterload sensitive. If you can see on the right side, the stroke volume of the right ventricle really breaks down if the afterload is too high. So it's a very, very careful monitoring of the right ventricle is an important thing. So for biventricular support, we were running into a situation in 2010 where we had to put in 2 HVAD devices. This patient came in as a myocardial infarction. We put in an HVAD, couldn't wean him off ECMO, and put a second device in. And to our surprise, it worked. And it was probably the first in the world that worked. And then we started to do that in 14 patients in between 2009 and 2011. That's still a Hanover experience. And 7 patients were prior on ECMO. In 4 patients, the LVAD implant was delayed, so it was not done at the same time. 2 patients had non-systolic heart failure, 7 female, 7 male patients. And you see the diagnosis again. And what surgical technique, first patient, I put in the device from the anterior wall. In 11 patients, we used a diaphragmatic wall of the right ventricle, and in 2 patients, the ventricle was so small, so we did an RA cannulation, standard LV cannulation at apex, and there was no restriction of the LVAD outflow. So this is how that looked like. And we lost 2 early patients, and these patients were the 2 who were unstable on ECMO before, and I think that's not a good idea to move on with this biventricular support if the patients cannot be stabilized on an ECMO before. Early deaths were these 2 patients. Transplants were happening in 2 cases over the year. Weaning from LVAD in 2 patients after 200 days. The right ventricle recovered, so we could wean them. Late death due to sepsis in 2 patients, 6 ongoing patients. So in principle that worked. And what we learned from this technology is, if you look at the flow curves of these patients, you can see there is a circadian rhythm in between the RVAD and the LVAD. So the pump flow is adapting to the physiology of the patient. And this is something we did not expect. That the flow gets down and up to the physiology, to the demand of the patient, without anybody putting any numbers, switching any speeds, or doing anything. So the circadian rhythm of blood flow was maintained in these patients with biventricular support. And how does this happen? Well, we tried to get a closer look into it and use this equipment for downloading the waveforms. And if you look down at the waveforms, we played around with that a little bit. So we had a patient here, we put the LVAD at a speed of 3000 RPM, and then ramping up the RVAD from 1800 to 2600. And you can see what happens is that the flow on the left side is adapting. Although the left ventricle is filling up, and this green shows you that the ventricle is filling up and is producing some pulsatility. But in essence, the flow on the left side was increasing without anybody changing any pump speeds, although we changed the speed on the right side. So it's adapting, it's maximum preload sensitive, and you don't have to take care of the LVAD speed. We also looked at what happens when these patients are sitting, standing, and walking, and I think this is a quite interesting interaction that's happening there. So for example, when patients are walking, the peripheral resistance came down, and so the pulsatility came down, and the right heart flow came up because there's a higher venous return. So these systems act to the physiology, and this is the characteristics that we found in this centrifugal pump technology, and I think this is the reason why it did work in these patients. We even weaned patients from these 2 patients, and so we went down with the LVAD flow, you see on the bottom, and stopped the LVAD, and then we could monitor that on the left side the flow remained stable, and that was a good sign to take the pump off. We took this further in a way that we have to remove a complete heart in the patients with myocardial infarction, a lateral wall tear, and ventricular septal defect. So the heart was beyond repair. And in this acute situation, patient came in on the ECMO, patient came in with aortic regurgitation. In addition to that, we removed the heart and put in these 2 devices. And this is how he looked like 2 weeks later, and with his heart removed and these 2 devices you see on the right side. And it also shows the disadvantage of the procedures, that for biventricular support, if you do it that way, people have to carry around still 2 bags with 4 batteries, and I think that is a very limiting step to this therapy. But we also looked at this as this response of the pumps if there's no heart to compensate anything. And you can see that when you increase the pump flow on the right side, there is a corresponding increase on the left heart function, or on the left pump function, without anybody changing the pump speed there. And if you have low flows or low speeds on the right side, there's an LVAD suction event. You can see that when you ramp up to 1800 to 2000 RPMs, out of a sudden the system works, and then the flow on the left side is basically depending on what happens on the right side. So no worries about overflowing the lung or doing anything, but these pumps control themselves more or less. Experience from Berlin was also in 17 patients, so I think this can be considered a safe therapy. And finally, a little look into the future. Miniaturization will be the next point. And so I don't know what will happen to biventricular support. We're looking in the lab. After these things, we used Jarvik devices in the animal experiments to look at biventricular support and the interaction of the pumps. We looked at the synergy pump to find out if there is a concept of biventricular partial flow. And my favorite at the moment is to keep the centrifugal pump on the left side, because it has this adaptation to flow that may not be there in axial flow technologies, and have a smaller pump on the right side. And these were also early animal experiments we did with a small LVAD on the right side and the centrifugal pump on the left side. All this investigation is not finished yet, so I can't tell you what is the definite thing for the future. But I do think that we will have some technology out there that is even better than what we have now for biventricular support, using smaller devices on the right side. So in conclusion, I think the HVAD can be used safely for biventricular support. Biventricular support is usually the answer to late referral hesitation and bad right ventricular management. And biventricular support is still used as a bridge to transplant because of this 2 bags 4 battery thing. I think that is nothing we can offer patients for many years. So I hope the industry will pick up on that and deliver us a system where both pumps can be run with 1 controller and 2 batteries. And I think that we would be using it as a destination device also. And this is about new technical developments we expect, and make biventricular support for the long term. Thanks for your attention.